Hello, greetings, everyone. I'm Jonathan Gingrich in the Dixon Poon School of Law here at King's. The Sowerby project. See if I can keep the order of these adjectives right. The Sowerby Philosophy and Medicine Project and the YTL Center for Politics, Philosophy, and Law are delighted to have everyone here today for an in-person talk with Craig Konnoth, a professor of law at the University of Virginia, who is an expert on health and civil rights, who's published in the Yale Law Journal, the Stanford Law Review, the University of Pennsylvania Law Review, among many other exciting venues. We're delighted to have him talking to us today about law, medical power, and minorities. And before we get started, I'd like to thank Elsie and Kingma, the Sowerby Professor of Philosophy and Medicine, I believe, for helping to organize this, to Winnie Ma, who has been instrumental in putting this event together, to Rivka Hatchwell for event planning, to Nick Makins for co-managing the event, and to Evelina for taking care of our AV and streaming. I would like to remind people to please wear face coverings. If you don't have a face covering, there's a table on the back of the room that has some masks available. And with that, I'll turn it over to Craig.
Thank you so much, Jonathan, and thank you all for being here. I know that there's still some uncertainty around in-person events, and I appreciate your coming. I also want to reiterate my thanks to Jonathan, to Elsie, and especially to Winnie, who was instrumental in pulling this together. I had a whole bunch of interesting travel events occur, and I had to keep troubling Winnie to move things around, and Winnie was just a really, really great sport about it. So thank you so much. All right, so part of the issue I faced was I did have the traditional suit and jacket, but that's either somewhere in DC or at Heathrow, not quite sure where that is. And also I had some very fancy slides, as I was saying earlier. That's what Americans are good for. But unfortunately, I'm not quite sure what happened to them. So we have one slide, and since I'm supposed to drone on for about an hour, if you doze off as I would, and come to, you'll hopefully see where I am. All right, so let me describe the problem that the talk's supposed to address by offering a few vignettes, each pertaining to different groups. First, Chinese Americans. On March 19, 2020, then President Trump briefed the nation on the COVID-19 breakout. As you know, he explained, my administration is working every day to protect the American people from the Chinese virus, replacing Chinese for corona in the prepared text. I've tried doing my impression. It doesn't work very well. Next, Black Americans. In the United States, COVID-19 death tolls broke down on starkly racial lines. Across the nation at various points in the epidemic, the death rate among Black Americans was about twice that of white Americans. In majority Black counties, adjusting for population, the death rate reached over 7 times the number compared to white Americans in those areas. The differences were attributed to policy failures, segregation, health discrimination, and other similar harms. Third, people who can become pregnant. Going further back, in 1977, the United States Supreme Court held that abortion, that abortion did not constitute a medical treatment and therefore could not be covered by state health insurance, what we have of that in the United States. But then in 2018, the Supreme Court reaffirmed another 1992 holding that said that abortion was a medical procedure. And so states could impose heightened so-called informed consent requirements, which often include misinformation designed to deter pregnant women from having abortions. Fourth, the same Supreme Court held that abortion was a medical procedure, held in 1999 that people with disabilities had to undertake whatever medical or corrective treatment was available to them before advancing a claim of disability discrimination. Now, Congress later overturned this holding, but until today, people claiming disability protections under the Americans with Disabilities Act, and even more so, Social Security claims, are given short shrift without exhaustive medical evidence evidence, and their subjective sensations must give way to the assessment of medical experts. Going even further back, gay people have historically been pathologized. Indeed, some queer theorists claim that the pathologization was important to and even fundamental to the concept of the homosexual. Through the last century and a half, homosexuals have been subject to electroshock and other aversive therapies. And while the DSM excised the main diagnosis that pathologized homosexuality in 1973, the subsequent decades have seen the repathologization of homosexuality. Indeed, through till today, nations justify their sodomy laws, usually relics of British colonization or American intervention, by associating gay men with HIV. In the United States itself, gay men are limited in their ability to donate blood for no clear medical reason. Largely, commentators believe, because of their miasmatic association with HIV. I was also the lawyer on a case where religious conservatives challenged regulations that California passed, the first in the nation, prohibiting sexual orientation change efforts in minors. So you get the large picture, but I want to finish with Miss Britney Spears. Now, most of you here are cooler than I am and younger than I am, so you've probably been following her situation better than me. But the conservatorship she experienced is part of the story, albeit a small one that I want to tell. Now, those were a lot of examples, but they all have one thing in common. Well, actually, they've got two things in common. They're very American-centered, which I apologize. That's the hazard of inviting Americans. But secondly, and more importantly, they are all examples where the state of law and policy results in the oppression of certain groups and individuals using medical frameworks, concepts, and ideas. Now, reviewing these examples, a large number of American legal scholars conclude that law uses medicine to oppress, coerce, and stigmatize, and therefore medicine and law should be sharply divorced. My central claim in this paper is that while there is oppression, that oppression is secondary to the main purpose for which law deploys medicine, primarily to construct reality. Law and legal agents use medicine to form an understanding of who humans are and how they tick. And then they produce a set of consequences based on those understandings. This means that medicine is not inherently oppressive or coercive. Rather, consequences that medical understandings produce in depicting reality for the law depend upon whose realities are recognized and prioritized. That, in turn, can be shaped by activism and engagement to ensure that the powerful engine of medicine can be deployed by the law to achieve justice. Now, I should note that this is not purely a philosophical investigation seeking to divine how many angels or doctors can dance on the head of a pin. There are real strategic consequences to the outcome of this argument. If we limit medical framing in policy contexts only where it is absolutely necessary, we might question the wisdom, for example, of treating racism as a public health crisis, as hundreds of municipalities in the United States have done, or litigate racism, or question the wisdom of litigating racism cases based on the trauma they cause individuals using medical frameworks, or question the wisdom of framing abortion as a women's health issue. An anti-medicalization approach would render us skeptical of these strategies. And indeed, critics that I can name, and I'm happy to talk about in the Q&A, have done impressive work documenting their skepticism with at least some of the strategies I have mentioned. Now, in addressing anti-medicalization critics, this paper seeks to draw a line more broadly between good and bad forms of medicalization. It agrees with critics that medicine can harm, but what it seeks to do is understand the nature of the harm at a theoretical level to delineate a clear space and agenda for engaging with medical oppression that both promotes anti-oppressive while seeking to target oppressive forms of medicalization. In what follows, as you can see in the roadmap, I'll offer a brief description of the philosophical underpinnings of my claims. Next, I will describe how law and its agents rely on medical power. Third, I shall show how medical oppression fits within this framework. And fourth, I shall contemplate possible solutions. Okay, so before we can talk about the law's use of medicine to oppress, it is necessary to lay out the philosophical basis of my argument. And my claim here is that legal agents and institutions use medicine to construct their understanding of reality with which the law must then reckon. This claim draws from a burgeoning field of philosophical scholarship, epistemic justice, which I know many of you are familiar with. Indeed, Winnie is one of the experts in the field. So hopefully we'll correct some of the inevitable mistakes I'm going to make here. Some American scholars have engaged with the field, but solely in the context of criminal testimony, usually those involving sexual harassment. While understanding how traditional evidence giving in these contexts is important, medicine here is unique in that it, more than any other field of knowledge, except perhaps economics, creates entire worlds and detailed imaginaries with which the law engages. It allows legal actors to make a claim regarding what the world is, and therefore what legal consequences must flow from it. Well, for those of us less familiar with this field, I'll offer a brief sketch, which is my own synthesis based on my probably imperfect understanding of the literature before turning to its engagement with medicine. Epistemic justice considers whether people are treated justly in their capacity as knowers. Miranda Fricker, one of the originators of the field, identifies two aspects of epistemic justice. First, testimonial justice, or rather testimonial injustice, is what she focuses on. And here I quote from one of her interlocutors. Testimonial injustice occurs when prejudice on the part of the hearer leads to a speaker receiving less credibility than he or she deserves. The most obvious case would be a situation where the hearer simply disbelieves an individual who is telling a story, even though that person deserves to be believed, maybe because that person is perceived to lack competence or honesty in the eyes of the listener. The second form of epistemic justice is hermeneutical. Hermeneutic, sorry. To quote again commentators and Fricker herself, the hermeneutic aspects of epistemic justice involve the generation of social meaning. And that includes, though it may not be limited to, the coining of words and phrases and indeed concepts to explain one's social experiences and the practices that give words and phrases the public meaning that they have. The way I think about it is, it really makes human experience legible. Hermeneutic frameworks allow individuals to express what it is they are going through. And hermeneutic disadvantage and harms result from the unavailability of labels, cases where understanding fails because the words are lacking, where we find a lacuna where the name of a distinctive social experience should be. And so a couple of examples that are common in the literature is that of sexual harassment, how women tried to express what sexual harassment was before the concept existed in the 1970s, or the concept of homosexuality, right? So growing up in India, I didn't really have a concept of the idea of the homosexual until I moved to the United States, because that wasn't in common currency where I grew up. So cross-cutting across the testimonial and hermeneutic aspects of epistemic justice are what I will, in part following Kristen Dodson, another philosopher in this field, call transactional and structural aspects. Transactional aspects involve individual interactions. In the testimonial justice context, a human resources representative might not believe a woman who claims she is harassed, perhaps because of his bias, perhaps he just thinks she's dishonest. Whereas structural aspects are those that shape the background conditions that affect who is believed. Thus, a company may have no complaint mechanism that would allow a woman to explain the harm she faced to a human resources representative in the first place. Similarly, because men structurally occupy positions of power in various companies, and power comes with credibility, a woman might be less likely to be believed. So background conditions can affect, the structural conditions can affect specific transactions, which show how transactional and structural aspects of injustice really lie on a spectrum rather than a binary, and can affect each other. In the context of hermeneutic justice, a specific individual might lack aspects to certain conceptual categories, right? So as I mentioned, because of the social situation in which I grew up, I did not have the concept of being gay in my head. Whereas a child growing up at the same time in the UK or the USA may have known what the term was. But again, this has to do with structural harm as well. the extent to which gay rights permeates certain communities and not others, the extent to which certain communities, those in the developing world, for example, have access to educational, economic, and media resources of those living in the global north and the like. Thus, the transactional harm is once more shaped by structural forces. The more localized a hermeneutic practice is, the less structural in nature it is, and the more generalized it is across society, the extent to which everyone really recognizes the terms and concepts involved, the more structural it is. Finally, and importantly, Fricker argues that epistemic harms, both testimonial and hermeneutic, can produce what she calls secondary effects. Thus, a woman might continue to experience harassment, psychological distress, negative job performance, and the like, if her claims of harassment are not believed. So let's put aside these secondary harms for the moment, so I might apply some of these concepts to how law deploys medical power. So the primary way in which law leverages medicine is to produce epistemic constructs that result in secondary effects that benefits some individuals and harms others. The law might do so formally. For example, in Social Security disability determinations, this is a program in the United States that determines who should get welfare distributions from states because they cannot work because of the individuals making the claims cannot work because of their disabilities. So in those claims, the law sets out a set of formal categories that lay out how testimony should be collected and what kinds of medical categories are relevant. Legal processes might also construct such evidence informally. That is, legal actors might make medical claims to justify policy without relying on formal medical evidence. In both cases, legal agents draw upon medical understandings developed by communities in which medical understandings are developed. So let me start by talking a little bit about what I mean by those communities. While much of medical knowledge might seem objective, in reality, groups within medical communities are often in disagreement. The extent of disagreement depends upon the issues and the actors involved. For example, in the COVID-19 context at various times, there has been disagreement over a range of matters, including COVID-19's etiology, origin, treatment protocols, and the extent of immunity conferred by contracting COVID-19, even among mainstream commentators. But non-mainstream commentators also claim medical authority. This includes individuals who have strong followings who believe in their medical authority, but might take different treatment approaches, like homeopaths or medical societies developed to promote certain causes. In the United States, prominent are communities formed around the practice of medicine with Christian values. But such groups might also go further afield and include medical professionals who are vaccine deniers, biblical counselors who claim that healing should be based upon divine rather than physiological interventions. All of these groups hold themselves out to be, and probably understand themselves to be, communities in which information they understand to be medical is developed and circulated. Sorry. Oh, that's great. Thank you. So these communities have their own account of what testimonial claims should be believed, who should be believed, and how to categorize the information collected. That is, they engage in both testimonial and hermeneutic construction of medical reality, right? So whether COVID-19 is real, whether vaccines work, whether homosexuality is a disease. Ultimately, it matters little for my purposes what exactly a medical community is, as much as that they are recognized as such by legal actors who then draw from the medical claims developed in these communities. Legal actors draw from these claims in formal and informal ways. Formal claims usually tend to draw from mainstream medical understandings. The best and perhaps oldest existing example of formal claims at the federal level in the United States is that of Social Security disability benefit determinations. The law shifts power away from claimants or patients and towards medical authorities, who are then given the decisive say over what is real. Thus, Social Security regulations state that, quote, statements about your pain and other symptoms will not alone establish that you are disabled. There must be objective medical evidence from an acceptable medical source. These regulations also lay out what harms will be considered legible for the purposes of Social Security, namely the hermeneutics for distributing benefits. State programs that predated Social Security did not require specific diagnoses in order for benefits to be distributed. Under the current framework, however, even if symptoms would prevent an individual from working, if there is no clear medically recognized impairment, medical category, an administrative judge to explain these symptoms, an individual cannot make a claim. Thus, in one case, an administrative judge believed that the claimant was in distress, but refused relief because the American Medical Association had not taken position on the disorder that was at issue there, multiple chemical sensitivity at the time. In yet another case, a judge recognized that a plaintiff suffered lower back pain that prevented them from working, but denied relief when the pain was not connected to any specific condition. Thus, when certain symptoms are organized within a conception of disease that allows individual to seek resources, but other symptoms are simply not cognizable, then the individual experiencing the first set of symptoms might experience a certain set of advantages. The testimonial and hermeneutic dynamics that invoke technical medical knowledge over lived experience are less apparent, but still present in various other legal contexts in the United States. Next, while in Social Security claims the would-be patient obtains a benefit by meeting a disease designation, in other contexts, they might also experience harms. For example, civil commitment or guardianship contests, such as, again, Britney Spears, involve debates over an individual's mental condition. We also see informal claims. So the descriptions I've offered so far pertain to formal criteria already established in the law, where administrative bodies and courts invoke statutes, regulations, and precedent, which in turn invoke formal medical criteria to determine what evidence to collect, how to interpret the evidence, and the like. But policy innovation often occurs by invoking the epistemic aspects of medicine in informal ways. So consider the COVID-19 pandemic. The ability of the states to develop and implement policy has depended to a large degree on how it has understood epistemically how policymakers and the electorate invoke COVID-19 in policy contexts. Controversy raged, perhaps still rages, as to whether COVID-19 is real or a condition made up to produce certain desired policy results or electoral outcomes. Whose claims matter to establish this truth is a key question in this determination. Similarly, and more informally, the hermeneutic aspects of understanding COVID-19 have been important. Some argue that COVID-19 should be understood as the flu, simply another disease that has a somewhat higher fatality rate. Others have sought to demedicalize COVID-19, claiming it is a bioweapon unleashed by a foreign power. Framing COVID-19 in this way has real consequences. One might believe that the evidence that COVID-19 is a phenomenon, one might believe that COVID-19 exists and is killing people, yet the hermeneutic framing of COVID-19 might determine our response to it. Importantly, the goal here is not to show that medical evidence being adduced is correct. Different medical communities might have wildly divergent views on what medical truth is. While formal claims do tend to draw on mainstream medical knowledge, that knowledge too can be incorrect. Indeed, while formal claims are more rigorously tested, legal agents might invoke medicine incorrectly or reach the wrong conclusion. For example, by refusing to believe a claimant who testifies accurately, or failing to recognize a condition such as fibromyalgia or multiple chemical sensitivity, both situations where the agency modified its position and admitting error in the first place. Similarly, in the early days of COVID-19, public health officials and politicians made claims that turned out not to be correct, such as statements regarding mask usage. Further, informal policy claims draw upon claims to medical knowledge that diverge significantly from mainstream understandings, including claims regarding the non-existence of COVID-19 or the inefficacy of vaccines or masks. But at this stage, I'm less interested in the veracity of the medical truths that legal actors draw upon. What I am interested in is how those making legal claims invoke these concepts, for better or for worse, in good faith or bad, truthfully or not. By invoking medical power, even in bad faith, they are seeking to make a claim to persuade judges, legislators, or even the electorate about the nature of reality, who is correct and who is not, what medical conditions exist and what does not. They do this in order to achieve policy change. So these policy changes constitute what Miranda Fricker refers to as secondary effects. These secondary effects can be categorized in two ways, external and internal. These are the effects that medicalization critics often identify as problematic. So we first see external effects. External effects largely involve benefits and burdens that the state imposes. Formal benefits include, for example, medical benefits through government and even private insurance programs, or access to drugs and other medical resources, which legally require the participation of medical professionals. Second are financial benefits, including social security benefits described above, and tax deductions or expenditures on medical conditions. Third, there are anti-discrimination provisions and accommodations in employment, public places, housing, and education, which again turn on medical determinations regarding the reality of individual experience. And there's a range of statutes that lay out several of these benefits. Formal burdens can range on a spectrum from commitment to forced medication in outpatient settings to surveillance. On the edge of the spectrum, involuntary civil commitment can occur if a court finds that an individual poses a danger to themselves or others based on medical evidence. Further along the spectrum, short of commitment, courts might place individuals in guardianship or conservatorship, usually based on medical advice, which gives to someone else decision-making power over medication, healthcare, but also financial matters, relationships, and sexual autonomy. Yet further along the spectrum is surveillance that can shade into coercion. For example, a law professor and anthropologist, Kiara Bridges, documents how women obtaining Medicaid assistance in the United States during pregnancy are compelled to meet with a nutritionist, a social worker, a nurse and health educator, and a financial aid officer. Conversations that ensue cover sexual activity, exercise, travel, seatbelt usage, and the use of medications. In all these cases, using medicine, law delineates a reality in which the individuals it constructs are cognitively unreliable, emotionally compromised, and existentially unstable, and therefore in need of control and supervision. Next, internal effects. Internal effects concern how individuals internalize the experience of how medicine operates through the law. It affects not just individuals who experience the external effects, so the individuals who are surveilled or who are claiming benefits, but society as a whole. Thus, individuals infected with COVID-19 may be treated coercively, forced to quarantine or isolate, which is an external effect. But such measures, among other education campaigns, also help internalize the message among those infected and not infected with COVID-19 alike, that COVID-19 should be avoided. Such actions, as scholars like Foucault most famously observe, inculcate within individuals a sense of the normal and promote good habits without costly supervision and control by the state. Health policy, since its inception, has been shot through with examples seeking to promote normal behavior and stigmatize behavior that is seen as medically harmful. So hand washing, mask wearing in COVID-19, the Affordable Care Act in the United States promotes wellness programs that in turn promote going to the gym and are anti-smoking, and so on and so forth. Each of these laws identifies certain behaviors as normal, and in so doing, denormalize and exclude other behaviors and characteristics and individuals. And some of the examples include smoking. So in the United States, various programs have taken steps to denormalize smoking and smokers, to denormalize obesity in various ways and to stigmatize obesity. And we can debate about whether this is good or bad, but the fact is that these secondary effects are the products of the law invoking medicine in various ways to determine what is obesity and what is smoking and how that fits in to individuals' daily lives. So, so far, as the last sentence I just uttered suggests, I've not really intended for my remarks to come across as prescriptive. One can debate whether smoking or obesity stigmatization is a good or bad thing. But what I mean to say is that law might deploy medical power for either good or ill. But using medical power, the law does produce oppression using medicine. In this portion of the talk, I first explain certain epistemic narratives regarding minorities that have circulated in medical communities, both mainstream and in fringe groups, over periods of time. Many of these narratives regarding Black people, women, people living with disabilities, and LGBT people are familiar tropes that I do not need to belabor. I next discuss the forms of oppression that is the secondary effects that the epistemic harm yield when legal institutions take these claims into account both formally and informally. So first, epistemic harms in medical communities. And I'm going to begin by talking about the dynamics of the epistemic harm. So in discussing the epistemic harm itself, let me concentrate on two specific dynamics. First, minorities are silenced. Second, they experience pathologizing stereotypes by those who are given epistemic advantages over them. First, patients who are racial minorities, sexual minorities living with disabilities, or gender minorities are silenced. This silence occurs at the transactional level because they are understood as dishonest or ignorant. And such individuals are also silenced at the structural level. For example, lack of access to employment in the United States prevents access to health insurance, and to medical providers. Even controlling for access to insurance means that these individuals have no medical professional, have no audience for their claims, for their explanation of their medical needs, which in turn prevents them and their experiences from shaping the pool of medical knowledge. The silencing of minorities means that stereotypes about them can circulate unchecked. The circulation of stereotypes constitutes testimonial harm in that it relies on narratives of those who are not minorities. This in turn produces hermeneutic harm, as minority experience is collapsed into or separated from medical categories in harmful ways. I break such stereotyping down in three categories. First, the identity itself can be pathologized. For example, people living with disabilities who are healthy or who seek to live without medical help, transgender people who reject medicalization, or historically gay individuals were placed into pathological categories in harmful ways. Next, defining characteristics of a certain group can be pathologized. Historically, for example, Black skin was pathologized as marking an individual, according to some medical authorities, as having certain kinds of disease. Blackness, of course, as a historical matter, was not sufficient or necessary to be considered Black. Scholars of race have documented. But skin color was strongly associated with race, and thus pathologization of skin color helped pathologize Black individuals in general. Another example includes the pathologization of pregnancy, which of course affects women to a greater degree. The third category includes pathologizing conditions which then affect some individuals more than others. The pathologization of civil rights activism as a form of mania in the middle of the century in the United States, for example, harmed Black people more than white people. Similarly, pathologizing hysteria, again, earlier in the century, harmed women to a greater degree. The distinctions I draw here exist on a continuum. As a certain characteristic is associated more and more with a certain identity, the pathologization of that characteristic results in the pathologization of the identity itself. So far I've focused on the dynamics of epistemic harm in medicine, but before I speak of the secondary effects, we must consider what are the results, the constructs of such harm. I break such epistemic constructs of minorities into three categories. First, through silencing, medical needs of minorities are erased. The silence equals death narratives that AIDS activism yielded captures such ideas. Similarly, pain symptoms of women and Black people are ignored, and their narratives of etiology, where minorities experience harm because of social determinants of health, and narratives drawn from social models of disability are put aside. Second, medical stereotypes that replace those erased narratives paint minorities as inherently inferior. Early medical sources claimed that women and Black people had smaller brains, and individuals with disabilities were infantilized, as disability scholars have long critiqued. Third, these stereotypes also created a narrative of contagion. Narratives of Asian people spreading COVID-19, or in the 19th century, yellow fever, Black people spreading Ebola, or gay people spreading HIV or AIDS, all draw from this dynamic. I don't want to belabor these narratives because they're frankly familiar to us all, but rather I want to map them onto certain forms of oppression, and most importantly, I'm running short of time, so I want to charge forward. So the secondary effects of legal oppression through medical stereotypes. The concept of oppression is perhaps best represented by the work of Iris Marion Young, whose seminal essay on oppression has largely defined the scholarship in that field. Young offers three forms of oppression that have received attention in subsequent scholarship and which are relevant for our purposes. First, there is exploitation, next powerlessness, and finally marginalization. First, exploitation occurs when, quote, a steady process transfers the results of the labor of some people to benefit others. The injustice here lies not, for example, in the division of wealth, but in the fact that the relationship involves a process by which the energies of the have-nots are continuously expended to maintain and augment the power, status, and wealth of the haves. The silencing of minorities permits their exploitation. Such exploitation occurs in two ways. The first occurs because the needs of minority individuals are erased, as I described above, even though these minorities continue to contribute to societies in ways that are equal to other members of society. And even though they have equal moral worth, they still do not receive the equivalent return. At a transactional level, for example, Black people's or women's claims regarding pain are routinely ignored. Similarly, when Black individuals, including some Black doctors, sought medical assistance for COVID-19 symptoms that they had, they were turned away, notwithstanding laws put into place to prevent such behavior. To be sure, some might claim that what we see here is not a law or policy harm, rather it is simply a social harm. But policymakers routinely choose to ignore, deliberately or not, certain areas of harm, in part because of the stereotypes of the group experiencing that harm. The AIDS epidemic, most notably, was disregarded by the Reagan administration for precisely those reasons. Further, such erasure can occur in formal legal programs as well. For example, Social Security and ADA claimants who are Black or women routinely face credibility deficits and receive benefits at lower rates than white men. The second way in which exploitation occurs is by creating medical stereotypes regarding minorities. Historically, for example, slavery was justified on the belief that Black people could labor in the sun to a greater degree than white people. Such claims are long and hopefully permanently dead, but such exploitation is not merely a historical relic. Some feminist theorists argue that laws banning abortion seek to exploit women by forcing them to bear children against their will. Yet those laws are justified precisely based upon women's purported psychological profiles. As Reva Siegel documents, anti-abortion justices on the Supreme Court and in state and anti-abortion legislators rely on medical claims that women are psychologically inclined towards childbearing and experience psychological harm after abortion to justify forcing women to produce children and to erase the experiences of those women who would prefer not to. Turning next to powerlessness, which I will refer to as domination. This form of oppression occurs when disadvantaged groups lack autonomy and are subject to the interference and control of others who set out the rules by which the former must live. Society justifies the domination usually by arguing that the disadvantaged group lacks the resources to determine their life course. To be clear, domination is conceptually separate from exploitation, though of course the two might occur together. A dominant group may exploit the labor or financial resources of a disadvantaged group without dictating specific life choices. And on the flip side, one might control the life choices of individuals without seeking to shortchange them or extract labor from them. Stereotypes regarding Black people, women, and people living with disabilities routinely justified such domination. On one hand, of course, these groups were silenced in medical contexts, which allowed medical professionals to overlook their agency. On the other, scientists claimed that Black people and women had smaller brains that prevented them from being able to make autonomous decisions. In the case of people with disabilities, the disability, whatever it was, justified similar claims. Such claims were used to justify a range of policies to control the decision of individuals living with disabilities. Again, these kinds of claims are not relics of the past. While crude craniometric measurements have fallen out of mode, policymakers increasingly draw on psychological claims. People living with mental disabilities are routinely coerced and controlled. Similarly, the example of abortion is once more telling. Not only are women exploited, but their decisions regarding their reproductive choices are dominated because they are attributed mental deficits, as Reva Siegel shows. Another facet of the argument that I described claims that not only will women experience psychological harm because their inherent desire is to have children, but also that in the moment they simply do not know that they will experience this harm moving forward. Similarly, communities pressing the right to continue sexual orientation change therapies argue that the issue is one of false consciousness. Gay individuals simply do not understand that they need to be cured, and that itself constitutes a clinical pathology. The situation is perhaps most obvious with individuals who fall into several categories: poor, female, pregnant, and of color, as Kiara Bridges documents. Welfare recipients falling into this category are told what they can and cannot eat as a condition of receiving welfare. They must report to social workers and are subject to drug tests. The final kind of oppression is marginalization, or what I will call exclusion. Exclusion keeps a group out of certain parts of society or out of all of it. Thus, African Americans and women might be excluded from certain jobs or certain foreigners from entering the country altogether. Exclusion is different from domination and exploitation. As Danielle Allen explains, exclusion constitutes a horizontal relationship, determining who is inside and outside. Domination, and presumably exploitation, is better imagined as a vertical relationship where power is exercised from on high. Indeed, more so than other forms of oppression, exclusion is somewhat mutually exclusive of them. If immigrants are excluded from the country, it is harder to dictate their life plans or exploit their labor, as it would be if they were in the country. So some philosophers note that a group might adopt a strategy of self-exclusion to avoid domination or indeed exploitation. Historically, exclusion was justified on three medical grounds: eugenic, the idea that intermixing of races would produce inferior offspring. Such justifications were routinely offered in cases justifying segregation and immigration exclusion. This form of reasoning has fallen out of mode. Second, exclusion was and remains justified on the ground that certain groups are carriers of disease. I won't here belabor the immigration bans of the 1920s or the 2020s against Asian immigrants in the United States, justified on the grounds of yellow fever and COVID-19 respectively, or the limitations on gay men donating blood in modern day United States to prove that point. Finally, exclusion was and again remains justified on behavioral grounds. Such justifications were and are used primarily in the case of people living with disabilities. Individuals assume that their behavior and governed by their capabilities will render them unable to participate in various ways in society. In the case of other groups, those grounds are less clearly medically defined, though many groups make assertions that sound in medicine regarding genetic tendencies towards violence among people of color, the fear that gay people might turn children gay, or the psychological deficits of women that might make them, for example, unsuitable for military and other contexts. Those claims, at any rate, feed into a broader dynamic, justifying the exclusion of various groups based upon medical or pseudo-medical characteristics. I want to emphasize two things in closing out this discussion. The law produces these harms in both formal and informal contexts. The results produced concrete and material harms in individuals, so-called external burdens, but they also produce internalized burdens, where both members of the majority and minority groups internalize lessons about who belongs and who does not, who is a social equal, and who deserves to be controlled and dominated. Such internalization can produce stigmatic harm and psychological and physical stress. Ironically, even as it focuses its narrative of medicine on various groups, our legal regime creates conditions that produces the need for medical attention. Ignoring that need is counterproductive. So where do we go? So this takes me to the last portion of my talk, which is addressing epistemic harm. And it is, as is the case when describing solutions, perhaps the least developed portion of the talk. So I welcome suggestions. But my core claim here is that there is a set of solutions, that we need not throw out medicalization altogether, as I would say the greater part of legal scholarship in the United States that considers medicalization would like to do. Rather, by ensuring minority groups have the chance to define their own medical realities, the law can produce feedback that supports minorities in defining their own medical and legal destiny. First, the law should support efforts to understand the epistemic reality of minorities by requiring medical institutions and agencies to take such harms into account. This involves cross-cutting efforts that take into account testimonial and hermeneutic harms. Such changes need to involve forcing institutional changes while also encouraging minority participation. They may be structural and transactional and must occur in formal and informal contexts. So the examples I'm going to offer are illustrative rather than exhaustive, and I break them down primarily into testimonial and hermeneutic categories. First, at the transactional level, debiasing efforts may produce some effects in certain contexts, such that the testimony of individuals who are minorities are heard in health insurance, public benefit programs, and the like. But legal change at the structural level has more promise, simply because of the nature of law, and frankly, because debiasing efforts have empirically been shown to be wanting. Testimonial remedies at the structural level include data collection efforts. For example, race-related COVID data for a large portion of the pandemic was simply not collected. Disability, sex, and LGBT data are still largely unavailable. While the Affordable Care Act requires collection of data based on race, and some data collection efforts in other contexts have occurred, there is a massive shortage of healthcare-related and other data involving various minority groups. The Social Security Administration's reporting on race data has also been fairly spotty. Other structural efforts would involve increasing access to healthcare for minority groups, for example, to increase interaction between minorities and the medical system. Similarly, when making decisions that affect medical care of minorities, such as legislation involving reproductive rights or sexual orientation change efforts, or triage protocols involving people with disabilities, legal decision makers should require input from groups engaged in that space, individuals belonging to that space, and whose views represent a significant portion of individuals who are affected. And that should occur at every level, from hospital committees to legislatures. At the same time, legal measures should encourage minority participation, both as listeners and speakers in the medical process. This includes grants and scholarship and incentives for increasing the representation of minorities in medicine. Indeed, the number of Black medical students has declined since 40 years ago, and individuals with disabilities are even less well represented in the medical profession. Next, public health efforts should encourage participation in healthcare. This goes beyond simply increasing access to insurance or offering money in minority neighborhoods that would support healthcare engagement. It might also involve providing grants to minority civil rights organizations to promote health promotion efforts among communities of color. At a more grassroots level, such efforts might involve distributing, for example, free devices for self-monitoring. As scholars have noted, there have been disparities in the uptake of self-monitoring and consumer devices based on race. Yet these devices have been key to promoting individuals' relationship with medicine as a means for self-conceptualization and understanding. Encouraging minorities to see themselves as fundamentally engaged with the project of healthcare, to see and perhaps most importantly, to know themselves as beings with medical needs and with medical stories to tell is vital. Encouraging individuals can produce not just active patients, but activist patients, which can shift the healthcare landscape. Second, hermeneutic changes. At the hermeneutic level, I envisage three key interventions. First, intervention at the medical and legal level to support diagnoses that support and recognize the stress minority experiences can create. A United States agency should require greater participation by minority stakeholders in the structuring of medical diagnoses within medical communities. For example, the ICD committees received heavy input from transgender individuals on gender identity related diagnoses. To be sure, not all diagnoses are as clearly aligned with a certain group, as in the case of trans individuals. But many conditions affect some groups more than others. For example, massively disparate rates of heart disease and stress are present among Black people, given the social conditions they experience in the United States. History involves examples of groups engaging in activism to produce diagnoses on the basis of which those groups receive help. For example, soldiers agitated for the development of a PTSD diagnosis in the United States. Coal miners agitated for the development and modification for lung diseases diagnoses affecting them. Similarly, women's rights activists supported the construction of concepts such as battered woman syndrome. Supporting and encouraging minorities to engage in activism to support the construction of diagnoses that recognizes the stressors of the minority experience can therefore be important and helpful. For example, in the context of heart disease, hypertension, and the like, which affect, as I said, Black Americans more than other groups. And there is precedent for such efforts. Not just the construction of diagnoses, but actually leveraging them in legal contexts. A litigation is pressed for the recognition that adverse childhood experiences arising from racism or homophobia can produce stressors, which in turn, as a legal matter, should trigger accommodations under disability laws. In some cases, schools have been required to take corrective action. Similarly, jurisdictions have recognized racism as a public health crisis. A next logical step would be to identify the harms that racism can cause and adopt measures to remedy such harms. To be sure, there is the concern that such efforts can be co-opted by those seeking to paint minorities as inferior and as pathologized. But an alliance of minority organizations seeking to support such understandings can, I believe, successfully combat such outcomes. Now, my first suggestion envisages a scenario where minorities can participate in describing not just the disease or the diagnosis, but also the cause of the diagnosis or condition. My second suggestion envisages that minorities will play a role in describing what they see as solutions, again, both in medical and medical legal settings. Solutions might involve medical intervention, but it might also involve social interventions that address root causes, such as environmental harm, homelessness, or unemployment. It might include accommodations for disabilities that do not require individuals to engage in body alterations. Such solutions shift the hermeneutic power that that creates solutions away from medical professionals and towards patients. Indeed, some minorities might still press for additional research, coverage, and funding, for example, for HIV cures or for gender confirmation efforts, which would still involve bodily alteration. But even in such cases, it is the patient's needs that would be centered in the experience rather than the conceptualization of medical professionals. My final suggestion has to do purely with legal change. In many situations, the hermeneutic outlook that law adopts is more parsimonious than that of medicine, even in contexts where law invokes medicine. Thus, the ACA penalizes smoking, and Social Security benefits and disability accommodations do not recognize addiction as a disability. factors which in turn disproportionately affect, for example, LGBT individuals who suffer addiction and smoking addiction, especially at higher rates. Similarly, the Supreme Court creates an arbitrary distinction, designating procedures designed to terminate pregnancies as medical, but those designed to preserve pregnancies, such as ultrasound and the like, as non-medical. Such arbitrary hermeneutic exclusions and distinctions that disproportionately affect minorities and do not follow medicine requires activism beyond the primarily medical worlds, such as ICD construction. Such activism must sound in the law. Ultimately, the goal of all of these activities is to assist minorities with reconstructing medicine and in turn its manifestation in the law, in their own image, to address the needs and the harms they face. Medicalization in the law can be deployed towards good if it is made the site of activism and social justice. So I'll stop there and I look forward to your questions. Thank you.